We have a new physician with us, a doctor of osteopathic medicine, Dr. Judith Glaser. And you've all, if you've gotten our newsletter, you've read all the details about her. She is from Long Island, and we hope that Dr. Glaser is going to become a very, very frequently visited member of our family. How is that? And I'd like to have her come up to the microphone, and I'm going to get off of this podium. Dr. Glaser knows a lot about post-polio, and that's why she was willing to come and talk with us, and we're delighted to have her. And she, before starting her own practice in Long Island, in New Hyde Park, she was, for how many years in Washington? 2.5 years, and at the National Rehabilitation Hospital, and where post-polio is a big issue, right? So I'm going to turn this over to you, but you might just want to follow me there and use that. And I'm going to get off the platform because it is your turn.
Does everyone hear me? Thank you. Yeah, I'm going to speak to you this morning about, I'm going to turn that off, about osteopathic medicine and a holistic approach to treating post-polio syndrome. I want to mention Dr. Laura Halstead because he's my mentor and how I got involved with treating patients with post-polio syndrome. I've had the pleasure of working with him for 2.5 years. He did retire from NRH, so he's still working in the Washington, D.C. area, but I'm still in contact with him, and he's really the pioneer of discovering post-polio syndrome. I'm going to cover an overview of osteopathic medicine and its principles, review post-polio syndrome, and discuss how osteopathic medicine and post-polio syndrome how osteopathic medicine can help post-polio syndrome. And then we'll have time for questions at the end. So what is osteopathic medicine? It's a focuses on the individual as a whole rather than just treating specific symptoms. It's a system of diagnosis and treatment for a wide range of medical conditions. It works with the structure and function of the body. So structure and function are interrelated. It's based on the principle that the well-being of the individual depends on the skeleton, muscles, ligaments, and connective tissues functioning smoothly together. For your body to work well, the structure must work well. There needs to be a state of balance, and osteopathic physicians work to restore your body to a state of balance with minimal use of drugs and surgery. It's still involved, but there's another pathway to help with disease and pain and function. We use touch, physical manipulation, stretching to increase mobility of joints, to relieve muscle tension and enhance the blood and nerve supply to tissue, and to help your body's own healing mechanism. We're trained to expertly evaluate the neuromuscular system and to seek to achieve normal body mechanics. This is what really differentiates DOs or osteopathic physicians from allopathic or MD. Do you hear me okay?
Yeah.
Thank you. It's what differentiates the osteopathic physicians from allopathic physicians or MD physicians, and I'll go into that a little bit more. We recognize the body's ability to regulate itself and mount its own defenses against pathologic conditions. I'm just going to brief slides to understand the difference. Well, the similarities is allopathic physicians and osteopathic physicians. It's both a 4-year medical training in the United States with an added focus on the neuromuscular system. We have a intensive training of osteopathic manual medicine or manipulative medicine, and just the philosophy is different, that the body as a whole. You're going to hear me say that a lot, but that's really, even if someone doesn't practice the manipulation, there's still a different approach to treating people. And we're certified in all specialties. So a little bit of history. The founder of osteopathic medicine was Dr. Andrew Taylor Still, who was originally an MD, so he was MD-DO. He was born in Virginia in 1828, and he was originally issued an MD degree by Missouri after a short preceptorship and some formal training. Back then, there weren't 4-year medical schools. It was, you had a preceptorship and a little bit of training, depending what state you're in. And unfortunately, he had 3 sons that died of meningitis as young children, just a few years old. So he was left feeling that regular conventional medicine wasn't really helping. At that time, a lot of medicine was for use of leeches and a lot of barbaric treatments that we don't use today. So he developed a form of manipulation to help keep the body fit with unobstructed circulation and innervation. He studied the bones a lot and tried to see how gentle manipulation or helping the body to heal itself. He started the American School of Osteopathy in Kirksville, Missouri in 1882. That school still stands today. And the first class graduated in 1893 with 5 women. And this is a quote from an article called The American Revolution, just on osteopathic medicine, that the musculoskeletal system is intimately connected with all other systems of the body through both voluntary and the involuntary nervous system. Thus, indications are that the musculoskeletal system is a mirror of both health and disease, responding as it does to inflammation and pain from disorder in other body systems. So if you look at osteopathic medicine in a little pie graph like this, you have your joints, your muscles, and your whole body system are connected. These are basic osteopathic principles that when we go through medical training and beyond that, this is how we look at treating people with all different conditions. That the body is a unit. Structure and function are interrelated. The body possesses self-regulatory mechanisms. It has an inherent capacity to defend itself and repair itself. When normal adaptability is disrupted or when environmental changes overcome the body's capacity for self-maintenance, disease may ensue. And that rational treatment is based on the previous principles. So after evaluation and diagnosis, you use everything above to formulate your treatment plan and use any manual medicine techniques, which again I'll go into. And these are corollary principles that movement of body fluids is essential to the maintenance of health. The nervous system plays a crucial part in controlling the body. And there are somatic components to disease. Somatic is muscle components to disease that are not only manifestations of disease, but also are factors that contribute to maintenance of the disease state. So what does this mean for post-polio syndrome? So first I'm just going to review post-polio syndrome. I'm sure you all are well versed on understanding the pathology, but it'd be good to be all on the same page and review it. So that's the polio virus under microscope. We got that. Just a little polio virus under the microscope. And poliomyelitis. There are 4 stages of the illness: the acute illness, a period of stability, stable disability, and then post-polio syndrome. This is a picture of the poliovirus here attacking the anterior horn cells in the spinal cord, which are the motor cells. And this is the axon, or the nerve that goes and innervates the muscle. This is basically a normal picture of the axon innervating the muscle. Then when the poliovirus attacks, you get loss of the axon, with some remaining axons innervating the muscle. During polio recovery, once the body was able to mount a defense against the poliovirus with your immune system, you were left with motor cells that were died off, but the body was able to grow branches. See, this was cut off, but this remaining axon grew branches to innervate the muscles. And that's how we were able to regain strength and recover. And depending on how severe the illness was at onset, depended on some of your recovery, so not everyone recovered as much, but still were able to recover some function and strength. And post-polio syndrome is when, after years of stability and years of your body adapting with the new branches, and the axon and the other remaining motor units here were not able to survive, mainly because the demand couldn't keep up with the supply, or the supply is not keeping up with the demand. So these axons were dying off. And what we find on EMG or nerve testing is that we see giant motor units, which are, I'm just going to go back to show you that this is a motor unit from the motor cell, the anterior horn cell, with the axon innervating the muscle. That's considered a motor unit, but when you get these extra branches, or in the picture before, you have these bigger than normal. So they call them, when you see it on the nerve testing, it's characteristic of polio, previous polio, that there's giant motor units. And when we do strength testing on the nerve test, there's what's called decreased recruitment, basically less strength. You see it on the nerve testing. Increased polyphasics, which is what you see in the muscle. You see that there's extra innervations, and that there's also was reinnervation and deinnervation, which means that the nerve axons were growing extra, or sprouting to develop more strength. So you see that on the nerve testing, depending on how much muscle is remaining. And again, this is just a picture, the same picture before, but that this is really what happens in post-polio syndrome, that it's not a flare-up of the virus, but rather an atrophy or dying off of the nerve axon. So currently, there's 750,000 to 800,000 polio survivors, and it's approximated that there's 100,000 people living with post-polio syndrome, that not everyone who had polio developed post-polio syndrome. The risk factors for post-polio syndrome is hospitalization at onset, 5 or more muscle groups affected at onset, acute polio as an adult, longer length of time since onset of polio, the presence of permanent impairment following recovery, a recent change in weight gain or physical activity, and being older at the time of diagnosis of post-polio syndrome. For most, onset of post-polio syndrome is gradual. For some, it may be triggered by a specific event, such as a minor accident or fall, or a period of bed rest or surgery. I've heard this a lot from people, that they were doing fine, or they had pneumonia, or were in the hospital for 10 days, or cellulitis, recently had a lady who had cellulitis, and all of a sudden, she's not walking as well as she was. And so it is, usually you see more of a gradual decline in function, but there are people that, again, have a sudden illness or a change and they feel see more of a sudden weakness. The Halstead-Ross criteria, named after Dr. Halstead. This was the original, when people were in the 70s and 80s experiencing new weakness and there wasn't a diagnosis yet of post-polio syndrome. This was what was developed as a criteria. That you have to have a history of polio. There's a period of recovery and then neurologic stability for at least 15 years. And then really the onset of new weakness, that's really what's characteristic of post-polio syndrome, with or without fatigue and with or without muscle or joint pain. And you have to really exclude other causes of new weakness, fatigue, muscle or joint pain. There's a lot of other medical conditions that can cause these, that can cause those symptoms, and it's really important for proper treatment. And this is from one of Dr. Halstead's articles that he wrote in Italian, that he learned Italian in his later years. That, this is, you start out at 100% where you got the polio virus, there was a pretty dramatic drop in strength. This is the strength and time. So the drop in strength and then, good amount of recovery over a short period of time, and then a period of stability over, I guess, about 25 years, and then just a slow, more of a gradual decline. And the triad of post-polio syndrome is the new weakness, pain, and fatigue. Currently, the consensus is that there's no cure to stop the deteriorating motor units. But most clinical trials are based on finding safe therapies to reduce symptoms and improve quality of life. Energy conservation and lifestyle modifications are important, such as assistive devices, mobility aids. And a lot of people ask about exercise. It's really individualized. There is controversy with encouraging or discouraging polio survivors to exercise because it can further weaken muscles. However, it is possible. I generally, depending on the person, recommend just upper body exercise for cardiovascular health and fatigue and general well-being, or seated yoga, gentle pool exercises to move and keep healthy. And it should be monitored by a physician. There were some studies and articles, depending on the number of muscle strength, how much exercise, and so there is a big controversy with exercise. But I was trained with Dr. Halstead. He really believed in not exercising polio-affected muscles. Not exercising polio-affected muscles. Strength exercising. Stretching is different, but it's really not recommended. Post-polio syndrome and pain. So just pain is that physical feeling caused by disease, injury, or something that just hurts the body. And a lot of people with post-polio syndrome, it's one of the triad suffering from pain. And I would say a lot of people that come to me, that's their number one complaint is pain. Oops, wait. So in post-polio syndrome, there's 3 types of pain. Type 1 is post-polio muscle pain, where it's really only felt in the muscles that were originally affected by polio. It's described as a deep ache, superficial burning, and improves with rest and heat and stretching. Also cramping. That's also a big complaint with polio-affected muscles, is cramping and foot cramping. Type 2 pain, or also called overuse pain, are injuries to soft tissue, muscles, tendons, and bursa, like tendinitis or bursitis, or bursas are all over your body. They're in between the tendons to help the muscles move smoothly. So a lot of these things get inflamed when there's weakness or overuse. And this is conditions that people without polio have. But a lot of people with polio, this is what their pain is from. And type 3 pain, or biomechanical pain, like degenerative joint disease, DJD, which is also known as arthritis, low back pain, pain from pinched nerves, like carpal tunnel syndrome or radiculopathy, which is also a pinched nerve in the spine, either the neck or the low back. So could have any number of areas, neck, arm, back, shoulder pain, with or without bursitis, myofascial pain, which is muscle pain, arthritis, polymyalgia rheumatica, which is another type of illness that affects the muscles. That's important to also rule out. Polymyositis, which is more of an inflammation of the muscles, not related to post-polio syndrome. Rheumatoid arthritis and tendinitis. And it's definitely a lot more up there, but for the sake of time, keep it short. So now I want to connect post-polio syndrome and osteopathic medicine. Now you have a little bit of an understanding of osteopathic medicine, and we reviewed post-polio syndrome. So, post-polio syndrome and osteopathic medicine. Again, osteopathic physicians treat the body as a whole unit. And with or without the manual treatment, I think, it's hard to, a lot of people, it's hard to explain exactly what osteopathic physicians do without the manual medicine, but in our philosophy, it's really, we're trained to look at the body as a whole, as opposed to just systems. So if you're feeling tired, maybe an allopathic physician might just take your blood and look at blood levels, if there's infection. We would do that too, but also look at structure and function and feel the muscles and balances of hip heights. Or I have a lot of slides to go through, so I'll hopefully I'll be able to explain that a little better. So again, we look at a physical exam, osteopathic structural exam. We use a term called somatic dysfunction, which means really, I guess, motor dysfunction. We feel the tissues, and if there's an imbalance, there's a way it's a terminology we use to diagnose it, and then we'll pick a treatment to balance the muscle, balance the bone, and bring back symmetry. Rule out other causes that cause pain, fatigue, or weakness. And again, the osteopathic manual treatment. It's also called OMM, osteopathic manual medicine, OMT. Depending on what school you trained at, there are different terms, and they change it from year to year. It is primarily used to treat musculoskeletal pain conditions such as back pain or shoulder pain, arthritis, and tension, but it's also used for many other medical conditions such as reflux, which is GERD, respiratory conditions, or general well-being. Also, respiratory infections. There were studies years ago where people with pneumonia did better in the hospital with osteopathic treatment of the ribs and diaphragm. Also with asthma, fibromyalgia, which is a muscle pain condition with fatigue. Pneumonia, bronchitis, again, overall health and well-being. The benefits is that it's non-pharmacologic. It's not oral medication. A lot of people are on a lot of medication, don't want more pills. So it's really a benefit. There's low risk of any complication, and it helps. The risk is you can experience some transient increase in pain or soreness, fatigue, depending on the treatment. And there's very high velocity, low amplitude treatment. That's the cracking, back cracking. That it's very rare unless the person does it, not doing it properly. But it's very rare that there'd be a risk of any complication or fracture or anything. These are a list of different techniques that an osteopathic physician would use. Myofascial release, muscle energy. Myofascial release is very passive. The patient's not doing anything, and the treating physician would do treatments for the muscles and the soft tissue and the ligaments underneath that. Muscle energy is more active for the patient, and the examiner, the treating physician would direct the patient to move a certain way and push a certain way to relax the muscle or restore symmetry. Strain counter strain is also passive. It's usually it's focused on treating certain painful points that are believed to cause a whole area of pain. Balance ligament tension, that's working on balancing the ligaments, and you actually do feel if you're balancing an area that's out of balance, you give it a little bit of push in the right way, and everything kind of balances out. And again, the high velocity, low amplitude, or low velocity, high amplitude are back cracking techniques. A lot of osteopathic physicians actually don't like to use those. It's chiropractors use a lot of the cracking. It does help, but really everyone develops their own tools to treat and what techniques they prefer to use. And there's also osteopathy in the cranial field. Also called cranial sacral technique. The cranial sacral technique is much more specialized. We only get a little bit of it in medical school training. You have to really take courses, or there are some people that do fellowship training in just manual medicine. And it's believed that there's tissues surrounding the brain and spinal cord that undergo a rhythmic pulsation. I felt it. It's pretty incredible, and not everyone believes in it. I believe in it, and people that have undergone it do feel the difference. There's a cranial rhythm that causes subtle movement of the bones in the skull, and you're able to detect these rhythms gently and gently manipulate the bones to kind of, if the rhythm is out of balance, you kind of gently bring it back into balance, and then the rhythm goes back to normal, and that is believed to help restore symmetry throughout. And again, some people, it is somewhat controversial, but if you talk to a DO, they'll tell you otherwise. So these are just some pictures. You may, if you undergo this treatment, the osteopath will put their hands around you like this, around your head like this, and you feel the rhythm. Or there's different techniques, different treatments. There's one called the CB4 that's believed to relax everything. A lot of during medical school, we were all stressed before exams, so we all wanted appointments at the clinic. And we believed that we got the CB4 technique, we passed our test. There's also, this is a treatment for sinus congestion. It's also partially cranial technique. And there are a lot of people that take their newborn babies because there's believed a lot of cranial trauma with birth. For back pains, this is a good area where osteopaths help a lot. And also just I'm a physiatrist or physical medicine and rehab, we're also trained to look at posture. It's very important. The hip level or iliac crest level could be from not just a leg length discrepancy, but they believe that the hip bones can be slightly rotated, pulling on a muscle, or slightly rotated forward or backwards or sideways, and it affects just the whole equilibrium and recruitment of muscles and function. Again, leg length discrepancy, a sacral torsion. The sacrum is the lower part of your spine, the triangular bone. Sometimes that is twisted in a way. Other people that have that condition are women who are pregnant. They have a lot of sciatic pain, and a lot of times it's from the sacrum being a little pulled in one direction or the other, and balancing that out, and the muscles out, just releases everything. There's one of the hospitals in the Bronx, St. Barnabas, they offer a 2-year fellowship training in osteopathic manual medicine, and they were recently on the news because they treat every woman who postpartum and some of the babies, and they interviewed a woman who said, she was in a lot of pain because of her sacrum being twisted, pulled, and so they have a very active service there at that hospital. And general muscle tension. So these are just other images of how, if you go or see someone being treated, this is what it may look like. osteopaths love to talk about the psoas muscle because it starts up here in the back, and it's a big muscle that goes down and it attaches on the leg. It's a hip flexor, and it often is pulling and straining, and it could be the cause of pain, walking difficulty. Joint pain, these are just other techniques. This is a picture of Andrew Taylor Still, Dr. Still, treating someone with elbow pain. And some of these, like this is a passive technique, this looks more of an active technique. He's probably telling her to push in a certain way. This is a carpal tunnel spread, where some of the carpal tunnel, you're kind of opening up the carpal tunnel, which is the nerve goes through that intervenes your hand, the median nerve, and kind of just opening it up to allow movement. Often relieves pain a lot. It can help the nerve heal itself and take pressure off the nerve. Oops. This is a scapular treatment to relax the muscles, help the shoulder and the scapula move better. An ankle treatment, again scapular, and that's the elbow. Going a little bit of fatigue. It's often a nonspecific complaint with a variety of possible causes. There's peripheral fatigue or central fatigue, and a lot of people who have post-polio syndrome, a lot of times it's the central fatigue. It feels flu-like aching, change in energy level. You often feel like you're hitting a wall at a certain point of the day. And if you rest, you feel rejuvenated. It's often very difficult to treat. Resting and taking naps are the #1 recommendation. But ruling out other causes such as anemia, depression, autoimmune disorders, disrupted sleep. I always ask people, do you sleep well? Often, if you're not sleeping well, it's really hard to say whether you have central fatigue or not. So you really need to have a good night's sleep to feel well rested in the morning. So ruling out sleep apnea, and also some medications, some blood pressure medications causes fatigue, or if you're muscle relaxants, those all cause fatigue. Fatigue and OMT, the craniosacral technique would be the way to go, but also just structural balance and restoring some symmetry could decrease just overall general fatigue on the body. The whole body and mechanics are supposed to be very minimal energy expenditure. So when something's off, you tend to use a lot more energy to move, and that's very fatiguing on the body. This is another area where DOs come in handy. Often with any pulmonary symptoms, there's rib dysfunction, meaning the ribs also have a certain movement. Even the upper ribs versus the lower ribs, they move in a different way. So there's gentle techniques that help the ribs get back to their normal rhythm. And also the diaphragm. The diaphragm, you see this picture here, when you breathe in, the diaphragm is supposed to go down so that your lungs can expand, and then it goes back up and you breathe out. Often, a lot of times people who have post-polio syndrome, their ribs, their lungs move in what's called a restrictive pattern. It just doesn't expand, the rib cage doesn't expand as well. Versus obstructive, which you see in conditions like COPD or asthma, where you just can't get the air out as much. So, but the rib movement would be different, or the diaphragm movement. These are just, you see there's a lot of little muscles. The diaphragm, you have the inspiratory muscles and the expiratory muscles, and there's a whole rhythm and pattern. This is a diaphragm treatment, the lower ribs also. And here are more pictures of, you see, treating the lower diaphragm here, another diaphragm treatment. Everyone kind of has their treatments they like. You can lie on your side. And this is a rib treatment. It's also often very gentle, the rib treatments. And also just helping, someone's not taking a deep breath, your treatments to help with that, and just makes a big difference. So neck pain is also benefits from osteopathic treatment. There was a small study of 183 people with neck pain and use of osteopathic methods provided greater benefits than standard physical therapy or general medical care. They showed faster recovery and fewer days off of work. And there's different, you don't only have to be lying down. There's different ways to treat, sitting up or lying on your side. These are just the other complementary treatments. Physical therapy, I'm sure a lot of you have had physical therapy. I often have people say they did a lot of physical therapy, it didn't help, or they got weaker. I recently, in New Hyde Park, found a physical therapist. I call her up, and she understands post-polio syndrome better, but often I send people just for modalities, which are the eSIM or the TENS unit, which is gentle electrical stimulation, superficial on the muscles, and it's believed to help with pain. It breaks a certain, it's called the gate theory, it breaks the pattern of pain. And ultrasound, which also helps with pain, ice packs and heat packs. And also physical therapy is good with, Washington, D.C., we had a good clinic where the patients had an hour of physical therapy evaluation and then another hour of occupational therapy evaluation. So even just learning how to transfer a little differently or do activities of daily living a little differently does decrease energy expenditure and help overall well-being, decrease fatigue, and just functioning better. There was a question, I got the email, I don't know if I asked it, but about trigger point therapy for myofascial pain. I'm going to go into that more in the next slide. All these massage therapy helps with muscle pain, chiropractic medicine. You just have to be careful, when you go to a chiropractor, just be careful that it's not causing more pain. Some people report that it causes more pain after they're not getting better. It's a different philosophy. They work more on the spine. But I have had patients that we found a chiropractor that helps a lot, and there's nothing wrong. If it helps you, it's great. Reiki and Qigong, they're just different energy treatments. I'm not trained in that, but I have people that have gone, and Reiki therapist uses their hands to move energy around. It's believed that a blockage of energy is causing pain. That's also the thought with what's called Qigong and acupuncture. Homeopathy, also there are a lot of DOs that also got trained in homeopathy and use herbal medication to help with symptoms. So trigger point therapy is needling of a trigger point for pain relief. Trigger points are, just gonna go to the next slide, they're areas in the body and the muscle that refer pain. And there's different theories why these trigger points are referring pain, but they're very painful. And one of the theories is that there's a lack of oxygen flow in that little area, so if you put a needle in it and you needle it a little bit, it brings new blood flow and heals itself. There's manual trigger point therapy. Some of the osteopathic treatments like counter strain. There's another one I didn't list, facilitated positional release. You kind of put the muscle and the trigger point in an area where it feels softer and then somehow it just releases. So these are just some referral patterns. Just going to go back to the other side. So there's dry needling versus needling with medication injected. If you use medication, it's lidocaine, numbing medicine, or markene's another type of numbing medication with or without a small dose of cortisone or sarapin, which is a plant herbal extract, which helps a little bit with the superficial nerve endings. It's another theory where the nerve endings might be irritated in myofascial pain. If you Google trigger points, you'll find a ton of information also. And just acupuncture in post-polio syndrome, it can help with pain, cold intolerance, fatigue, general well-being, and other conditions. I also became certified in acupuncture, and I had acupuncture done myself, and it's pretty incredible. There's a physician who came up with a protocol for post-polio syndrome, actually, certain points in the ear. And the ear is, even if you go for ear acupuncture, it's believed that it helps even without needles in the rest of your body. And so just gonna we'll have time for questions. We're going to go through a few slides just to sum things up. But according to the Global Polio Eradication Initiative, our generation stands on the brink of eradicating the second human disease in history. Polio has disabled millions, and especially in third world countries, there's a lot of poverty, and it's really been reduced by over 99% in the last 30 years. We've been able to bring immunizations, and India now is polio free. As of February 2012, only 3 countries remain endemic: Afghanistan, Nigeria, Pakistan. We're down from more than 125 countries just from 1983. And a couple of years ago, I was at the European Polio Union meeting. This only started up again. This was in Copenhagen at the Hans Christian Andersen Little Mermaid statue. It's very famous there. People would keep moving it further out in the water because people steal her head off, apparently. But it's pretty cool. So I was there in 2011, presented a poster with Dr. Belsa didn't go, but we worked on a small study together of younger patients with post-polio syndrome. Because in Washington, D.C., we saw a lot of immigrants they're mainly immigrants. There were 1 or 2 people that had vaccine-related polio, but we kept seeing a lot of younger people. So we did a small poster study, just chart review, and we found a lot of the younger people were complaining more of fatigue because of just their life demands. They had children and work job demands. And not all of them actually, very few of them actually had post-polio syndrome, but I think this year's conference, there's one in June 2012, they're focused on the younger patients, because in Europe, there are a lot of people from Pakistan, the endemic countries that are moving to these countries, so it's a big concern just for being able to provide medical care for polio-affected individuals. So I would, if you're into traveling, I actually really enjoyed it because, went for a week and went to it was like a 3-day conference, and I got to see Europe a little bit. And these are just some resources I don't know if anyone's been to the Round School of Osteopathic Medicine in New Jersey, it's on the UMDNJ campus. And they have a academic health clinic, and so does the New York College of Osteopathic Medicine, and Toro College is one of the newest osteopathic schools, and it's in Harlem, New York. And if you're interested in going for osteopathic treatment, these are very good resources. It is covered by insurance. But if you go privately, there are a lot of people that, if they're just focused on osteopathic medicine, they do not take insurance. People do, it's very good. People will pay out of pocket for treatment. But again, at the clinics, it's good because you get a lot of attention there. It's academic healthcare clinic. That's where, this is where I went to school at New York College of Osteopathic Medicine, where we went before our exams. And there's also Find a DO from the American Osteopathic Association. So you could, I'm sure everyone's from different areas, but you could look up a DO near you. And also the American Osteopathic Board of Neuromuscular Medicine. This is where people get board certified in neuromuscular medicine or osteopathic treatment. And I want to end with a quote. When you have adjusted the physical to its normal demands, nature supplies the remainder. And that was by Dr. Andrew Taylor Still. And I hope it's a helpful talk for you. And if you have any questions, I'm here to answer them. I can't tell you.
Could you repeat the question?
Sure.
Please.
So, tell me your name. Carol. Was asking, first she underwent myofascial trigger point release and found it helpful, but she was at a physical therapy conference where she saw that the fifth year physical therapy students were being taught that strengthening exercises is what's recommended and not some of the myofascial release and trigger point or modality therapy. And why is that? I think that they're not being taught properly on post-polio syndrome. I don't know if it's, where I worked at NRH, that wasn't the issue. And when I send someone for physical therapy with post-polio syndrome, I always make sure to talk to the physical therapist because I want to make sure I'm on the same page as them. And it's important, I think, if you're going to a physician, I think that would be the best way to go. I don't know, I'm not involved with physical therapist training, but I agree with you, it's not what's recommended. I think if you come across someone, you should give them resources like the Polio Health International website. There are a tremendous amount of articles and resources, but I unfortunately can't tell you why they're no.
I saw it as a warning, and as a survivor group, like, how do we communicate? Look, this is just not good for most of us. The students, they study PPS.
Mhm.
That's our group.
I mean, again, there is some controversy with exercise. When I was at the meeting in Copenhagen, you can do some exercise with avoiding fatigue. So I don't know if they're trying to get that across, but I definitely that you can't strengthen polio, and post-polio syndrome. But if you can give them my information, I'm happy to talk to them. And I would just say try to educate. Yes.
I can agree with you. My mom lives she's 90, and she lives in independent living. I'm a physical therapist, but we were not taught about, I'm 66, and we were not taught anything about polio, which would have been the right time. But I learned, because my mom had polio, but they're trying to get her to walk. The whole thing is strength. They want her to walk and walk in the dining room. And I'm saying, you don't get it. She can't walk, so she falls, and then she gets injured. So it's really insane. So I ordered several books from the foundation, and I took them in, I highlighted them, I took in everything and said, listen, this is what you need to know. Because it's a problem. And they're young.
Yeah.
And I'm saying, you're not learning the right thing. You don't get it. They're not going to walk. She's not going to walk. Right?
Yeah. It definitely is a challenge, but I think it's casual.
Yeah, this is been 30 years ago to polio-related conferences and everything. It's the first time I ever heard rib pain addressed, and I've had rib pain.
I've had rib pain, I've always been told, well, my doctor is like, listen, you've had it for 30 years, it's not going to kill you. But can be quite excruciating. I've never brought it up because, like I said, this is the first time I've ever heard it addressed. And I was just wondering what the therapy is to do something about it, and if anything can be done after all these years of, kind of just dealing with it.
Did everyone hear the question?
No.
She asked about rib pain. She's been to conferences where no one brought up rib pain, and she has suffering from rib pain, and someone told her, you've had it for 30 years. So, rib pain is definitely could be muscular. You can have referral pain, and it could just be the muscles tightening. It could be from mechanics, if you're walking or transferring a certain way, overusing one muscle. So I think you can, haven't evaluated you, but I think it's worth looking into. And the techniques, they're gentle. They would muscle techniques. And keep in mind, it may not get better after one treatment. It's going on for 30 years, but yeah, thank you. You're welcome. On the back there.
Are you familiar with the Healthy Bowls program that they do with the different wives in the area?
Is that for like arthritis? Or-
Yes, yes, but of course, you do things with weights.
Mhm.
You know, and I'm wondering, do you think that that's beneficial or not? Because I've ended up with a shoulder pain that I never had before, so, thank you. Yeah, I think, I think the shoulder pain is as a result of using a weight on this hand when I probably shouldn't have.
Was that arm polio affected before? Or?
No, never.
So again, that's where there's a lot of conditions that tendonitis and maybe just from people can have muscle imbalance without post-polio syndrome. And generally, the arms, our arms are not meant for weight bearing like our legs are. So light weights are often okay, but maybe it is too much or you have a rotator. Yeah. So if it's hurting, don't do it.
Right, exactly.
And get evaluated.
Right. Thank you.
You're welcome.
Thank you.
This lady in the.
How do you distinguish post-polio syndrome from other conditions and also coupling it with general aging and being overweight? So that's one question. And then the other question is, because a lot of us don't do weight bearing on our legs very much, how do you cope with the osteoporosis issue other than taking a medication, which I'd rather not do?
So the first question is, how do you differentiate post-polio syndrome from other conditions? So being that there's a lot of other conditions, it's hard for me to say that for everything, but you have to have the right evaluation. You may or may not need a nerve test. If there's back pain or pinched nerves, if there's pain, fatigue, it would be tweaked out like that. Have you ever seen anyone before?
No, I mean, that's part of the difficulty. I'm from New Jersey, and just trying to find a practitioner that's familiar with polio and post-polio is almost impossible, but also, excuse me, have you ever seen a crossover? Like, is there any people that may have yet developed MS or other similar muscular diseases that could, you automatically think it's post-polio syndrome.
Right.
But, anyway, just
Yeah,
curious.
there are people that have other effects of nerves or pain conditions, but there are ways to evaluate. You may need some testing, and that's why it's so important to rule out other causes. And if there's no one specifically for post-polio syndrome, you can start with a neurologist, depending on your conditions. Someone who's a physical medicine or rehabilitation specialist. We did have a little bit of training with post-polio syndrome, and at least they could differentiate where some of your pain or new weakness is coming from. That's the best I can tell you right now. And the osteoporosis is challenging if you can't weight bear, and definitely medication. There is the injectable medication once a year, which is now thought to be safer than some of the oral medications that you would take weekly or monthly. So that's one of the biggest challenges. But definitely, I think anyone with weakness, if you can still do stretching, that could help. Some of the tug on the bone might help. Yes?
Dr. Glaser, how are the students at the osteopathic schools introduced to post-polio syndrome? Do you ever go, or is there a lecture for them?
Good question. So I have not, as of now, got involved with, since I've been back in New York. I moved back a little over 2 years ago, but I have given talks at the residency program for North Shore Long Island Jewish for the physical medicine and rehab physicians. So that's a good idea, though. I should contact them and give a talk. And in Washington, there was also a residency training program, and I gave a talk at Georgetown. So I guess depending where you are, if there's someone who's knowledgeable on it. That's what I can say. But
I was interested to hear you saying that Dr. Alstead didn't push a lot of exercises? Do you mean like you can be doing gentle exercises like?
Yeah, I'm a big proponent.
But he wasn't like for trying to, run or walk so many miles a day, like after, so many years you have to decide. And best advice a doctor ever gave me was that you know your body, and if they tell you to swim 4 lengths and you can only do 2, do your 2 and not. And so a lot of this, I think people are confused. You think I gotta, what they used to say about, push yourself and do it, you can do it, no pain, no gain, which is not true. And, but you get all those thoughts, so you have to kind of figure it out yourself. And so I was interested in what he thought about the exercises. I don't know if I got it right. You said not too much. Do you mean not too strong exercises or gentle exercises?
So it's generally recommended that the polio-affected muscles, that you can't strengthen them. So you don't want to do strengthening exercises. It's not to say that you shouldn't do any movement. You can think of your energy or your strength in a sort of an energy bank, and you have, like you said, you can do 2 lanes or 2 errands a day. If you can do activity within your energy allowance without fatigue or pain, whether it's a little bit of walking or depending on your strength level, that's okay without causing fatigue. But Dr. Hall said he recommended for people that did not have their arms affected originally with polio, or if we did the nerve, we could often do a nerve test, and if the strength is good or there was no polio whatsoever, you can exercise as much as you want with the arms. But it's definitely with polio affected muscles. If you have, strength is rated out of 5. So if there were people that had a 4 out of 5, we had a lot of people that like to take walks, and over time it was more exhausting, but often rest breaks. They'd walk a few blocks and just try to avoid fatigue, but that was just for like leisure, not necessarily for strengthening. But
Simple question. What's the difference in fatigue and tired?
So I went over a little bit peripheral fatigue. He asked what's the difference between fatigue and being tired. I think it's synonym, same word, but there's different, people, if you wake up feeling tired, I think it's a little bit different than the central fatigue that a polio survivor might feel towards the middle of the day, where you feel like you're hitting a wall and you just like have to lie down or close your eyes. There are people that had to pull over, if you feel like you have to pull over on the side of the street if you're driving and take a nap. That's really like polio type of fatigue. And this lady, what's in your neck? Oh, you sorry, yeah, the mic. You go first with your microphone.
You had mentioned water therapy. Do you know of deep water running, and do you subscribe to that? 'Cause I've done, what I do is get up to my neck in water, and I run in place rather than going through the water, because the water gives resistance.
Right.
And
You still get resistance just running in place, but I think what's great about water therapy is you could actually be buoyant and move the muscles, and it's really what the other lady said, if you know yourself well, if you're not experiencing fatigue or pain after the end of the day or the end of the week, then, but yeah, if you run underwater though, it is, with the resistance, it's more energy expended than running on dry land. But if you're just doing gentle movement, and then I think that's great. Yeah, I'm a big pool person. So.
My question is there a difference in effect on the body that's had polio between active exercise and passive exercise? Would it be better for people like us to have a machine be doing the work?
Well, passive exercise is either another person or machine moving you. So you're not strengthening muscle. So that would be more like strengthening or just range of motion exercises, which I think is safe, generally is safe with post-polio syndrome. You're not going to get the same effect of strengthening, but you shouldn't be, if you have polio-affected muscles, you shouldn't be strengthening them. And then active is really strengthening, you're doing the work. So.
It takes one more question.
It's Johnson over there.
Hi, this is my first time to any of the polio meetings, so I'm really happy to be here. Thank you so much. I'm learning so much, and I know you mentioned that you saw a lot of immigrants with polio. I'm one of them. So my concern is now I have enough information. I know I'll try to join the group and try to be part of it, but where do I go in 20 years?
Good question. I hope I'm still around in 20 years. Be around. I'm not planning to leave the New York area. I hope that, I think, that's why Dr. Halston and I tried to bring it to polio, the world of polio attention, and in this meeting in Amsterdam in June is actually, if you look up European polio meeting, they're really focused on younger people now, immigrants. I don't know what's going to happen in the, this area, but I think there could be more immigrants like you, and I think staying active in groups like this. Also, if you hold the Polio Health International, I think they put my poster board up. It might be hard to find from a couple of years ago, but I think it's on the website. You can see that there are more people like you, and hopefully there'll continue to be resources. Yes.
Thank you so much, Judith. I knew that I learned more about what's going on with my muscles and bones in a long time. I knew that this would be a very informative session, and I think your questions have been terrific. Would you agree with that, Judith? Yeah. Great questions. And I want to thank Judith very much. And is John still here? Where's John? Judith came today with her fiancé. I don't think. Oh, there's John. So we want to say very nice to know both Judith and John. And good luck for the future. And thank you so much for this very, very informative talk. And what I wanted to say now is that the staff, we want to stop now because